Hi everyone, I am Dr. Pratyaksh Verma and welcome to my show, which is Study Family Medicine with Dr. Pratyaksh Verma. Today we are going to discuss an important topic, neonatal jaundice. And it is really important as a family physician that you have a good hold over this topic because definitely the families are going to present to you with their newborn kids, and neonatal jaundice is one of the most important problems that the neonates present with. When I was posted in pediatrics ICU, I remember in one night duty, the parents came with a newborn kid of 2 day old, and the kid had jaundice. I thought that it was important to take some action and admit the kid for phototherapy. But as the pediatrician came and said that it was just physiological jaundice and needs just monitoring, I thought that okay, some jaundice can be can be physiological and they can recover over time. So, what are we going to cover in this uh, podcast? The difference between physiological and pathological jaundice, the difference between breastfeeding and breast milk jaundice. How are we clinically going to estimate bilirubin levels as a family physician? What can be the causes of neonatal jaundice, and when should you get alert as a family physician? How to approach jaundice? Why it is important to address neonatal jaundice in neonates? Because it is one of the important problems of neonates. High bilirubin levels are toxic to the developing neurological mechanism or the central nervous system of the neonates. 60% term neonates are visibly jaundiced and no intervention has to be taken for that. Whereas the 5 to 10% clinically significant jaundice may require phototherapy. What are the difference between physiological and pathological jaundice? The physiological jaundice is due to the immaturity of neonates to handle increased bilirubin production, whereas the pathological jaundice usually occurs after 24 hours, and the total serum bilirubin levels are above expected normal range. It is the presence of clinical jaundice beyond 3 weeks, and the conjugated bilirubin picture is there, means there is the dark urine stained nappy. And in physiological jaundice, the visible jaundice occurs after 24 to 72 hours, in between these 24 to 72 hours. The total serum bilirubin level in physiological jaundice peaks up by 3 days of age and then falls, whereas in pathological jaundice arbitrary limits have been taken. If it exceeds 5 mg per deciliter on first day and 10 mg per deciliter on second day, or 15 mg per deciliter thereafter in term neonates. And the phototherapy is not usually required in physiological jaundice because the total serum bilirubin levels is below the designated cutoff for phototherapy. Whereas therapeutic intervention have to be taken, investigations have to take place in pathological jaundice because the treatments benefit more. What is the difference between breastfeeding jaundice and breast milk jaundice? In breastfeeding jaundice, basically the pattern is uh, when the babies are breastfed and when they are artificially fed, the patterns in both of them, the jaundice pattern is different. In breastfed infants, it usually appears between 24 to 72 hours age, peaks by 5 to 15 days, and disappear by third week of life. And 1/3 of all breastfed babies are detected to have mild clinical jaundice by third week. It may persist up to second to third month of life. And why this is caused? Because there is inadequate breastfeeding, and the treatment is to ensure optimum breastfeed. Whereas the breast milk jaundice, the pattern is that jaundice is more than 10 mg per deciliter and beyond 3 to 4 weeks of life. The frequency is that 2 to 4% of exclusively breastfed term babies are develop this breast milk jaundice, and it is usually unconjugated. It does not stain nappies. The mechanism is that the jaundice is prolonged and the cause has to be investigated, and it can be due to hemolysis or extravasated blood, G6PD deficiency, or hypothyroidism. There may be X number of causes. The treatment is phototherapy, and we need to keep monitoring the bilirubin levels. How to clinically estimate bilirubin levels? With the help of Kramer staging. Basically, how Kramer classified it was by classifying, putting different areas of body into different classes. Zone 1 is contains head and neck surface area, and the bilirubin levels are usually 4 to 6 gram per deciliter. Zone 2 contains the chest area, and the bilirubin levels are between 6 to 8 gram per deciliter. Zone 3 contains lower abdomen and thigh region, and the bilirubin levels is usually estimated approximately between 8 to 12 milligram per deciliter. The zone 4 is arms, the upper arm and the lower arm, and the area between knee and ankle in the legs. And the zone 4 is estimated to be approximately between 12 to 14 gram per deciliter. Zone 5 is the palms and the feet region, and it is usually estimated more than 15 gram per deciliter. The jaundice usually progresses from cephalocaudal direction, and how it is checked: you have to blanch the skin of forehead, chest, abdomen, thigh, leg, palm, and sole, and it usually gives yellowish tinge. What can be the causes of neonatal jaundice? It are broadly classified into two, basically hemolytical and non-hemolytic. The hemolytic causes can be due to Rh incompatibility, ABO incompatibility, G6PD deficiency, thalassemia, hereditary spherocytosis. The non-hemolytic causes can be prematurity, extravasated blood, inadequate feeding, polycythemia, idiopathic breast milk jaundice, and hypothyroidism. When should you, as a family physician, become alert and take some action? If the jaundice occurs in first 24 hours, if there is blood group incompatibility, and for example positive direct antiglobulin test, for example in hemolytic diseases like G6PD deficiency, if the gestational age of the mother is between 35 to 36 weeks, if there is a history of previous sibling who received phototherapy, if there is cephal hematoma, if there is inadequate breastfeeding with excessive weight loss. How to approach neonatal jaundice? First is that we should perform visual assessment of jaundice every 12th hour during initial 3 to 5 days of life. The visual assessment can be supplemented with the transcutaneous bilirubinometry if it is available with you. The first step is, does the baby have serious jaundice? If the baby has serious jaundice, then we should start phototherapy and monitor serum bilirubin levels and determine whether the baby requires phototherapy or exchange transfusion. And step 3 is we should determine the cause of the jaundice and provide supportive follow-up care. If the baby does not have serious jaundice, we should ask the question whether the infant have significant jaundice to require serum bilirubin measurement. If it does not require, then observe every 12th hour. If it requires, then definitely you should go for serum bilirubin measurements and find the cause of the jaundice. When to say it is a serious jaundice? When there is presence of visible jaundice in first 24 hours, or the palms and the soles have turned yellow, or there are signs of kernicterus. Now you should remember the signs of kernicterus. The kernicterus is that the serum bilirubin levels have started affecting the brain. So there may be hypertonia, abnormal posturing such as arching, retrocollis, opisthotonus, convulsion, fever, high pitched cry. Basically, bilirubin is irritant to the brain. So all this are a result of irritation. Measure serum bilirubin if jaundice is within first 24 hours. If the jaundice is beyond 24 hours, then do the visual assessment or the transcutaneous bilirubinometry. And if the total bilirubin is likely to be more than 12 to 14 milligram per deciliter, then you can go for phototherapy also. If you are unsure about visual assessment, then go for serum bilirubin measurement. Now let us talk about phototherapy. Basically, the mechanism is that the insoluble bilirubin or unconjugated bilirubin is converted into the soluble isomers that can be excreted in urine and feces. The light which is used is from blue to green range wavelengths, and it is 460 to 490 nanometers. Bilirubin is converted to luminobin, which is basically water soluble and can be excreted from the urine. Also, we should remember to cover baby's eyes and expose maximal surface area of the baby to ensure good hydration and nutrition of the baby. How are we going to prevent neonatal jaundice? By doing antenatal investigations. Do maternal blood grouping. If the Rh positive baby is born to Rh negative mother, then there is high risk of hyperbilirubinemia. So ensure anti-D injection if the first obstetrical event decreased sensitization. Ensure adequate breastfeeding. Parent education. We should explain the danger signs to the parents. If there is yellow discoloration below the knees and elbows or persistent jaundice beyond 15 days, then action has to be taken. If there are high risk babies or large hematoma, or there is history of family in which someone developed this neonatal jaundice, we should follow up after 2 to 3 days of discharge. Now, after this podcast is over, just take few minutes and write the summary and what did you learn from the important value points. Take care, and let's meet next Sunday at 3 p.m. Same day. Let us meet again. See you all.